Bismillahirrahmanirrahim. In this video, we will discuss the embryology and anatomy of endocrine module discussed in first aid. So let's start with thyroid development. Thyroid gland basically develops from primitive pharynx. During the course of development, it descends and goes to the normal location in the neck. And this structure is called as the thyroglossal duct. This thyroglossal duct normally disappears. So in a normal person, there are only two remnants of this thyroid development. First remnant is the point of origin or from where the thyroid gland started its descent, and that is a foramen at the tongue called as the foramen cecum. The second remnant is a pyramidal lobe of thyroid. Pyramidal lobe of thyroid. So in a normal person, there is no other remnant. Now there can be abnormalities in this development. First abnormality to be discussed is the ectopic thyroid tissue. Now this is the most common abnormality. What happens is that some portion of thyroid is still left at this area, at the tongue, or you can say the primitive pharynx. There can be a normal thyroid along with this ectopic thyroid, or this ectopic thyroid can be alone without a normal thyroid. Now, how does a patient usually present is that you will have a patient, a boy at the age of 14 or near puberty, and he will be having symptoms such as difficulty in breathing, dysphagia, and hoarseness. The reason behind this is that although there was some tissue since birth, but the production of thyroid hormones from this ectopic thyroid was very less. So there were no symptoms. At puberty, there is a rise in hormones, and that rise of hormones leads to these symptoms. That rise of hormones leads to enlargement of this ectopic thyroid. So this is basically a typical clinical presentation of ectopic thyroid tissue. The treatment is simple, removal of that ectopic thyroid, but removal can lead to hypothyroidism, which is definitely treated by hormone supplements. The second abnormality of thyroid development can be a thyroglossal duct cyst. In a normal person, I already mentioned there is no thyroglossal duct, but in an abnormality, there can be a cyst along the course of this thyroglossal duct. This cyst usually moves with the movement of tongue or moves with swallowing, and this is specifically high yield because this differentiates it from persistent cervical sinus, in which there is no movement of the lump at neck with swallowing. This means that even in persistent cervical sinus, there is a protrusion on the neck, but if it is persistent cervical sinus, the protrusion will not move with the movement of tongue, and if it is a thyroglossal duct cyst, it will move with the movement of tongue. Now let's have a look on the cells. There are two main kinds of cells. There are thyroid follicular cells, and second is the parafollicular cells. Thyroid follicular cells produce the main hormone called as the thyroid hormone, which is T3 and T4, and parafollicular cells produce calcitonin, which has a role in the calcium homeostasis. Thyroid follicular cells are derived from endoderm. These derivations are particularly high yield. They may test this knowledge of yours. And parafollicular cells are derived from fourth pharyngeal pouch. This is the embryology of thyroid discussed in first aid. But let me tell you some anatomy from using this diagram also. You must know that the thyroid has a blood supply by superior thyroid arteries and the inferior thyroid arteries. And the superior thyroid artery is first branch of external carotid artery, whereas the inferior thyroid artery is branch of thyrocervical trunk. And of course, thyrocervical trunk is originated from left subclavian vein. So you must know about this blood supply of thyroid gland. The rest of the structures are not that high yield, so I am not discussing that right now. Now I have just mentioned few extra points which I feel are really high yield. So first point is already what I have explained it on this diagram. The superior thyroid artery is first branch of external carotid artery, and inferior thyroid artery is branch of thyrocervical trunk. Now, as far as the parathyroid glands are concerned, so parathyroid glands are derived from third and fourth pharyngeal pouch. So now you can relate this information. We have the parafollicular cells of thyroid derived from the fourth pharyngeal pouch, And then we have the parathyroid gland derived from third and fourth pharyngeal pouch. Let me show you a picture of the parathyroid gland. So there are four parathyroid glands located posteriorly near to thyroid, and you can see there are two superior thyroid glands, the inferior thyroid glands. Now, a very interesting point is that the superior parathyroid glands are derived from fourth pharyngeal pouch, and the inferior parathyroid glands are derived from the third pharyngeal pouch. This is all about the anatomy of parathyroid gland. We don't have to discuss it further. Now, another syndrome which I found high yield but is not discussed in first aid is the Kallmann syndrome. What basically happens in the Kallmann syndrome is that there is a developmental defect in the gonadotrophs. So the cells producing these gonadotrophs are not migrated. They do not migrate from their original location. Their original location is somewhere near the olfactory area. So they are unable to migrate from their original location to the normal location. What is the normal location of gonadotrophs? In the pituitary gland. Due to this defect, you will have a patient with hypogonadism, since there are decreased gonadotrophs, and anosmia. So hypogonadism along with anosmia suggest Kallmann syndrome. And I found another situation also in which there was hypogonadism along with anosmia, and that was zinc deficiency. Zinc deficiency also have hypogonadism with anosmia, but there are other symptoms also in zinc deficiency, such as loss of taste, night blindness, impaired wound healing, and erythematous plaques. This was all about the embryology of endocrine system. Now let's have a look on anatomy. Now there are a few high yield points discussed in anatomy. First, we will discuss the pituitary gland. The pituitary gland is divided into the anterior pituitary and the posterior pituitary. The anterior pituitary is also called as the adenohypophysis, whereas the posterior pituitary is also called as the neurohypophysis. Now let me tell you the development of pituitary gland. Now, development of pituitary gland is very high yield. All you find over here is that the anterior pituitary is derived from the oral ectoderm called as the Ruthke's pouch, and the posterior pituitary is derived from the neuroectoderm. That's all what you get from first aid. But let me tell you what is this Ruthke's pouch. So you may have a look at this diagram. Look at this diagram. This pink structure is the derived from the ectoderm, and this is basically the primitive oral cavity, right? So you see a pouch arising from this oral cavity goes up, and this forms the anterior pituitary, whereas a structure coming from the neuroectoderm, this yellow structure, forms the posterior pituitary. That is why this posterior pituitary has a very strong connection with the hypothalamus. We will see that there are neurons which have their cell bodies in the hypothalamus and their axon endings in the posterior pituitary, whereas anterior pituitary is relatively differentiated from hypothalamus. So anterior pituitary is derived from ectoderm and posterior pituitary is derived from neuroectoderm. Now, once these points are clear, let's go back to our first aid. The secretions of anterior pituitary are follicle stimulating hormone, luteinizing hormone, adrenocorticotrophic hormone, thyroid stimulating hormone, prolactin, growth hormone, and beta endorphin. Beta endorphins are basically used to relieve pain. And a very interesting point is that there is an intermediate lobe of pituitary, and this intermediate lobe releases melanotropin. So melanotropin stimulating hormone. So MSH is released from intermediate lobe of pituitary, not the anterior or the posterior, intermediate lobe. Another point discussed over here is that TSH, LH, FSH, all of them have two subunits, an alpha subunit and a beta subunit, and they all have same alpha subunit. So what basically differentiates TSH from LH and FSH and the HCG are the beta subunits. So beta subunit is different. That is what is written, that determines the hormone specificity. Now coming towards the posterior pituitary, as I already mentioned that there is a strong connection between the hypothalamus and posterior pituitary. Let me show the connection to you. As far as the secretions are concerned, there are two secretions of posterior pituitary. One is the oxytocin and the second one is vasopressin. So now have a look on this diagram. This is the hypothalamus and this is the posterior pituitary, this being the anterior pituitary. Now there are two secretions of posterior pituitary. One is the vasopressin and the other is oxytocin. But both of these hormones are just stored and secreted in posterior pituitary. These hormones are produced in the hypothalamus. So in the hypothalamus, we have paraventricular nucleus, which mainly forms the oxytocin, and we have the supraoptic nucleus, which mainly forms the vasopressin. So you can see that the cell bodies are in the hypothalamus. So these hormones are produced in the hypothalamus and then they are transported along this axon with the help of carrier proteins called as neurophycins. This is also important. There are carrier proteins called as neurophycins which carry oxytocin and vasopressin from the hypothalamus to posterior pituitary. Another point to remember is that if there is destruction of posterior pituitary, so there can be an intermittent shortage of oxytocin and vasopressin. Or if there is any defect of neurophycins, so there can be a short period defect or short period shortage of oxytocin and vasopressin. But in the long term, still these hormones are being produced in our body. So one way or the other, they are going to come in the blood ultimately. Now, once we are done with this also, let us go to adrenal cortex. Now, as far as the adrenal gland is concerned, we have the adrenal cortex and the medulla. The outer region is called as the cortex, which is rather more important, and the inner region is called as the medulla. This cortex is derived from the mesoderm, just like the thyroid follicles, and this medulla is derived from neural crest cells. So it is derived from the neural crest. What are the secretions of cortex and medulla? To memorize it, we say GFR, glomerular filtration rate. So basically the cortex have three layers. The outermost layer is zona glomerulosa, the intermediate layer is called as zona fasciculata, and the innermost layer is called as zona reticularis. So zona glomerulosa, fasciculata, reticularis. All three of them have a particular secretion. The secretions of glomerulosa are mineralocorticoids. They regulate the salt. And the secretions of fasciculata are glucocorticoids. They regulate sugar, or you can say sweet, because they regulate the glucose levels. And then we have the zona reticularis, which regulates the androgens, which are the sex hormones. So we say salt, sweet, and sex, right? Salt, sweet, and sex. SSS, salt, sweet, and sex. GFR. Right. Now you should know how are these secretions regulated. So mineralocorticoid, which is aldosterone, it is primarily regulated by the angiotensin 2. As you know, angiotensin 2 is produced by renin-angiotensin aldosterone system. So you see there is aldosterone at the end of this name. So aldosterone is regulated by ACTH, and the other two secretions are regulated by aldosterone is regulated by angiotensin 2 and the other two secretions are regulated by ACTH. Now ACTH is released from the pituitary, right? It is the anterior adrenal corticotrophic hormone, and CRH is released from the hypothalamus. What basically happens is pituitary is kind of a master gland. It regulates several secretions, and the trophic hormones released by pituitary are further regulated by hypothalamus. So hypothalamus is like kind of a boss. Corticotrophin releasing hormone from hypothalamus regulates the ACTH from pituitary, and this ACTH from pituitary mainly regulates the production of cortisol in the adrenal gland. All right, and then we have the medulla. Medulla have chromaffin cells, and these chromaffin cells produce catecholamines, which means epinephrine and norepinephrine, which are responsible for your autonomic nervous system, the sympathetic and the parasympathetic nervous system. And the release of these epinephrine and norepinephrine is regulated by preganglionic sympathetic fibers. So this was all about the adrenal cortex. One more point which I have to mention is that the left adrenal vein drain into left renal vein. I'm sorry for writing artery over here. It's left renal vein. Let me show you a diagram for a better concept. Have a look at this diagram. You can see that this adrenal vein is draining into the renal vein. whereas the right abdominal vein is directly draining into the inferior vena cava. So we have a long renal vein. You may remember that the gonadal vein also drains into the left gonadal vein also drains into the renal vein, whereas the veins coming from the right testes go directly into the inferior vena cava. So the right renal vein is smaller and the left renal vein is larger, so it drains more structures, it drains more veins into it. Last but not the least is the endocrine pancreas cell types. Basically, we have islets or Langerhans for the endocrine secretions. Pancreas is kind of two organs at one place. It have an exocrine function and an endocrine function. The exocrine secretions are basically the hormones, so basically the enzymes which are released into the GIT. But the endocrine pancreas release other hormones into the blood. So we are discussing endocrine pancreas. The endocrine hormones are released by islets of Langerhans. These are kind of islands of cells. Three of them are important: the alpha, beta, and delta. Alpha cells produce glucagon, beta cells produce insulin, and beta cells are the most abundant one, and delta cells produce somatostatin. Now, the alpha cells, which are producing glucagon, are at the periphery. You can see these yellow cells at the periphery, right? And the beta cells are in the central location. You can see most of the center is occupied by the beta cells, and these delta cells are some, interspersed between them. So I hope you enjoyed the video. We will discuss further topics in the coming videos. Thank you very much.